Good evening, everyone, and welcome to Updates on Glioma Surgery. My name is Isabel Germano. I'm the chair of the IINS Global Neurosurgery Committee, and it is a big honor and my pleasure to be with you tonight with this incredible panel of faculties from the United States and from Africa. This webinar is in collaboration with the Continental Association of African Neurological Surgeons. And tonight we will share some of the great steps that neurosurgery has taken in the African continent. With that said, I would like to also share with you just a couple of things about the IINS Global Committee. This is a committee that is aimed at fostering timely access to safe and affordable neurosurgical care to all by serving as a forum for the exchange of knowledge among neurosurgeons around the globe and a catalyst for advocacy of common interest among neurosurgery organizations worldwide. And this is really the theme and the reason why we're here tonight is this knowledge exchange is so important that we learn from each other. One of the programs we established is a resident education global exchange, whereby the Australasian Society of Neurological Surgeons, the Federation of Latin American Neurological Surgeons, and the Continental Association of African Neurological Surgeons are each year selecting one resident and sending it to train with one of the courses that the IINS NREF is putting together. Please take a look at this program. It's on the web, and feel free to contact your Continental president to see if you could be a candidate. The other thing that we establish is a IINS Global Neurosurgery web, and here is the website. And there are a couple of things I would like to highlight. One is that we have online courses that are basically free of charge for our international members. So if you're not a member, you can take the survey and tell us why you're not. But if you decide to be a member, there are multiple benefits. And the other thing that I would like to remind everyone is that we have an international global forum that is coming up at the IINS meeting, and you're welcome to submit a slide for that forum. You can do that tonight, right after this seminar. So that brings us to tonight, and it's really exciting and a big honor for me to introduce Professor Alessandra Golby, who will be our next speaker on the topic of updates on glioma surgery. Alexandra, when you're ready, you're on. And it appears that you're still muted.
Okay. Can you see and hear?
We can see it, and yes, we can hear you.
Great. So thank you very much, Professor Germano, for inviting me to speak at this webinar. I was really excited to receive the invitation because it combines two things that I'm very passionate about. One is neuronavigation and, in general, using technology to improve brain surgery. And the other is sharing those innovations with colleagues in lower resource settings. One of the great things about neurosurgery, one of the reasons many of us go into it, is that it is so dependent on technology and benefits so much from technology. And our ability to perform successful brain surgery has really been predicated on these technologies that you see evolving over the last 100+ years. And really what they share the most is the ability to localize and visualize the pathology in such a way that the target can be obvious for the surgeon. So cross-sectional imaging, operating microscope, endoscopy, all of these help the surgeon to see better. Today, I'm going to focus on neuronavigation as a critical and sort of foundational tool for neurosurgery. And the reason I say that is that it brings many of those other approaches to visualize. So it can bring cross-sectional imaging, it can bring functional imaging, it can be a way to record intraoperative neurophysiologic findings in a 3D data set. The system uses computer-assisted surgical guidance, and it does require preoperative imaging. This is usually MR or CT. And one important point to make is that it's not real-time imaging. So the imaging is obtained before the intervention and loaded into the system. But it is real-time localization. And so the ability to see the location in 3D in real time allows surgeons to know where they are, plan trajectories, establish the boundaries of lesions, and generally be more accurate. And you can see here, this is an instrument in the virtual data set aiming towards the lesion that's been contoured and colored. I often describe this as GPS for the brain, and I think that parallel is really valid because GPS or low cost GPS, which we all have through our phones, has completely revolutionized our ability to get around. I, like many of you, came of age before we had a pocket GPS, and I got lost all the time in my city of Boston, which is a crazy city for driving. And now that just doesn't happen anymore. And I think that there's the similar level of confidence in navigating with navigation as opposed to doing it without. And that's really what it offers. So it allows us to be more precise. In being more precise, we can localize and avoid eloquent structures or blood vessels or white matter tracts that we're trying to preserve. It also allows us to make smaller craniotomies. Starting with craniotomy planning, it can help outline the margins of the lesion, anterior, posterior, medial, lateral, and really avoid the need to make a much larger craniotomy. The other reason it avoids that is because you're no longer looking for anatomic landmarks. So you don't necessarily have to expose, say, the midline if you didn't need to, or the Sylvian fissure. And because of these smaller craniotomies, patients have fewer complications, the surgical time is shorter, and the patients wake up in better shape, had less of a invasive intervention. It's often shorter, and it's really a beautiful thing to see people go home 1 or 2 days after surgery. This is how navigation works. So in general, it requires registering the preoperative imaging, which is CT or MRI, to the patient. And this is obviously not a real patient, but a phantom that we've been using for our studies of navigation. And we do a registration, and this is the registration happening on the video, where the surface of the skin is acquired with the pointer, and the pointer has been digitized, so the computer system recognizes it when it's in the field. And so it is able to generate this surface or point cloud, which then can be matched to the surface from the imaging. And that's how registration is performed nowadays. And then the surgical instruments can be tracked and displayed on the 3D imaging. There are 2 basic forms of navigation, electromagnetic and optical. Optical is the more dominant system because it's more accurate, and it's been somewhat commoditized. Electromagnetic systems, though, do absolutely have their role. One of the things is that they don't require line of sight between the instruments and a camera. They work with a low intensity electromagnetic field that is generated by a generator that's placed near the head. And then the instruments can be detected in that field and their position can be calculated. So that is very helpful for a number of procedures, in particular because it does not require pinning the patient in the head clamp. But its downside is that it can be sensitive to metallic interference from instruments. So it's important when actively navigating to move the system, move any large metallic instruments out of the way. As I said, optical systems are really the most common system used in day-to-day navigation. They use infrared cameras that can track the location in 3D of these reflective spheres or other reflective markers. As I mentioned, it does require a clear line of sight between the camera and the instruments, and that can sometimes be difficult in a busy operating room. But optical tracking has the highest level of spatial accuracy in everyday use and is the most commonly used. So in the operating room, we have a number of steps that we do. So first, the reference frame has to be attached to the patient's head. In the case of optical imaging, it's attached to the Mayfield head clamp. And so the whole thing is one rigid construct. In the case of electromagnetic imaging, the reference frame can actually be just stuck to the patient's forehead with a sticker. And in optical navigation, then the camera has to be positioned in such a way that it can see the instruments, and the navigation screen has to be positioned in such a way that the surgeons can see the screen clearly without being too unergonomic. And we can see the cardinal views, the axial, coronal, and sagittal views, but we can also reslice images as long as they've been acquired with thin cuts or in a 3D fashion. We can slice them in what we call an inline view. So that's like a diagonal cut that follows the planes that intersect where the probe is pointing. And that also allows you to look ahead. So you can look at where the instrument will be by adding a virtual tip to the instrument, 1 centimeter, 4 centimeters. And this is really helpful for a number of procedures. We're talking today about tumor resection and stereotactic biopsies, are core tasks as tumor surgeons, but it's also very helpful for other things like deep brain stimulation, epilepsy surgery, and skull base surgery. I've been very interested in making navigation more affordable and more robust and nimble so that it can be used in lower resource settings. The commercial systems that we use cost many hundreds of thousands of dollars. They usually require the use of disposable parts, that single-use pieces that cost quite a lot of money and often require a service contract or a software subscription. And so our goal is to really provide this so that the surgeon can have a helping hand, essentially a kind of expert guidance. And this can be helpful in the most simple way, for example, avoiding wrong side or wrong site surgery. And it can also be helpful in sort of more sophisticated ways, like establishing the extent of resection during surgery to maximize that. So we've developed the system. It's called NewNav. It is developed collaboratively with partners in many different countries, and we continue to develop this. This is an example of how the system works. So it's very analogous to any optical system, but it uses a very inexpensive camera. So the kinds of cameras that are used for optical systems used to be very rare, but now they're used every day in a number of consumer electronics parts. Our system fits in a briefcase so that the clinician can take it from place to place. And the components are very affordable. The most expensive component is the camera at $3,000 and the laptop at about $500 to $700. The prices on the laptops keep coming down. And then the other pieces are either custom made, and we've developed a way of making them for just a few $100s, or they are purchased off the shelf. And we've used a lot of camera photography hardware. And we, as I mentioned, we don't want to use expensive consumables, so we engineered a way to cut circles from reflective tape, the kind of tape that's used on sporting clothes or sneakers. And we established that that was as accurate as the reflective spheres. And we built the system on an open source platform. So the core software is 3D Slicer, which is software that you may be familiar with. It's used in research for many different kinds of image processing. If you are interested in image processing, or you have students or residents who want to start to work with imaging, I highly recommend 3D Slicer. It's free and open source, and there's a lot of training for it. We also worked with colleagues in Canada who developed the Plus system, and the core component, as I mentioned, is a camera that's open source and readily available. We tried to make the system as simple as possible, so every step is outlined. It's reduced to its most essential essence. Our navigation registration takes just a few minutes. And I can actually say that today in our state-of-the-art OR, using a state-of-the-art robot, it took us about 10 times as long to do the registration as with our little homemade system. This is training people in the use of the system. So training is critical, as with any tool. It can be misused. It can give wrong information due to a number of issues that can happen. And so training in recognizing that situation is critical. This is my colleague and friend Claire Karakezi in Kigali showing it to her colleagues. And this is another colleague. This is Magat Guy, who's a neurosurgeon in Senegal. And she was one of our first adopters to bring this into the operating room. And I'll just play this video.
Alors, là, je suis face projectile sur la lésion. Oui. Oui. Le bord antérieur. Hein? Le bord le plus latéral. OK, là. En plein dessus. En plein dans de la lésion. Ici. La limite externe. Externe, super. Allez, notre lésion est là. Son volet est déterminé. Fais les photos et tu viens larguer.
So that's a little recap on navigation and why I think it's such a critical tool that we can hang so many different procedures on, so many different types of imaging, and really refine our surgical trajectories and provide our patients with the best possible care. And I'll be very happy also to answer any questions at the end of the webinar. Thank you.
Thank you so much. This was a great lecture. And as you mentioned, we're going to keep all the questions for the end. I would like to invite Professor Mahmoud Abbasi from Egypt to take the podium and share the slides.
Hey, thank you for the invitation. And one of the things that I want to say that I do like the NONAV system because even in low middle income countries, if you're capable to get a neural navigation system, it's still so expensive, and the maintenance is really expensive too. And if you have a problem with one of the parts of the navigation system, it's very difficult to get a new part. Sometimes it takes up to 6 months to be able to import a new part to replace it. So it was really a good idea to make a low-cost thing like that. So I will talk about the accuracy of the bold and DTI images for cortical and subcortical mapping. I'm Huda Bassi. I'm an associate professor of neurosurgery at Alexandria University, and I work as a consultant of neurosurgery in the Cancer Children's Hospital of Egypt. As a background, surgical management of gliomas that are near adequate areas shifted with the new technologies from conservative biopsy to maximum safe resection, as gross total resection is increasingly correlated with improved overall survival, even in high-grade gliomas, but more importantly, of course, in low-grade gliomas. In current practice, it relies on two pillars, actually. The use of neuronavigation system using the diffusion tensor imaging and the tractography, and of course, the bold MRI for preoperative planning, in addition, of course, to the intraoperative neuromonitoring for real-time functional verification. What is the bold MRI? The bold MRI, it depends upon the blood oxygen level that maps the brain activity by measuring the changes in the blood oxygenation. The MRI is capable to check the differences in the magnetic properties between oxygenated and deoxygenated hemoglobin. Active neurons, they require more oxygen. During the bold MRI acquisition, the patient inside the MRI is asked to perform certain tasks, like, for example, word generation, like, for example, moving his hand, moving his foot, and accordingly, the active areas of the brain started to show increased amount of oxygen that are flowing to these areas, causing a significant difference between the levels of the oxygenated and deoxygenated blood. Diffuse tensor imaging is another modality of imaging in which it maps actually the white matter tracts. And this is according to the diffusion of the water molecules through the neural fiber pathways. The axons is the thing that through which the water can pass. For example, in the white matter is full of axons that are covered actually with myelin sheath. And the water can only go through the axons, not across the myelin sheath of the fibers. And therefore, it shows the tracts, the corticospinal tracts and other tracts of the brain. This is how the bold MRI is populated into the neuronavigation system. Of course, this is one of the very expensive neuronavigation systems. The patient is asked to do certain tasks. When he do the task, there is elevated amount of blood oxygen level. When he doesn't perform the task, there is decreased amount of blood oxygen level in this area. And a statistical analysis is done to compare between the active paradigms and the inactive paradigms in order to be able to populate the active area, in this case, for the hand part. And accordingly, a volume can be populated from the active areas and to be able to show the active part of the motor strip that is responsible for the movement of the hand. The DTI, to be able to do the DTI, you put a region of interest over the motor strip, another region of interest over the cerebral peduncle, and then you ask the computer or the software to be able to show how the water flows from one region of interest to the another region of interest. In this case, it is showing the corticospinal tract. But what about real-life practice? So when this started in the early of this millennium, actually, there was some papers were written to compare between the diffusion tensor imaging and tractography of different tracts and intraoperative subcortical stimulation. And it was showing here, for example, the arcuate fasciculus, and here it is showing the corticospinal tract. And there was a very good correspondence between the positive stimulation types and the fiber tracts. However, some issues, for example, like if there's vasogenic edema surrounding the tumor, sometimes there is negative tractography. And negative tractography in this case doesn't rule out the persistence of a functional fiber tract, which means that even if you have a DTI on a navigation system, you cannot rely on it 100%. Still, you need intraoperative subcortical stimulation in order to detect the tracts. Another interesting article from Neurosurgical Review, it was done in 2023. They did a meta-analysis, and they found actually that the DTI group achieved a higher rate of gross total resection, and also it gave a similar result to the intraoperative cortical mapping. But still, the combination of both is superior to either method alone in order to do both of things, maximal surgical resection in addition to safety of the patient. what are the problems of the DTI and the bold? There are some pitfalls, or there are some things that may distort the image of both of them. Like, for example, physiological noise. It distorts the bold MRI. Motion, especially that you are asking the patient inside the MRI to perform certain tasks. Acquisition harder sequences limitations. Neurovascular coupling, areas that are full of blood vessels, they are showing more oxygenated hemoglobin, problems with the statistics. In addition to all of this, you are still depending upon preoperative images and not real life images. It's very difficult. There's no way, for example, to do, even if you have an intraoperative MRI, you cannot do a bold MRI in an intraoperative MRI. The patient is already asleep. And the other thing, that if you're going to do a DTI to patients that are performing intraoperative MRI, you have a problem that it will be so much time consuming, and it will be so much impractical to acquire the data and then acquire the diffusion tensor sequences and then to populate the DTI images. For example, this is a case in which the patient had what looks like a low-grade glioma at left frontal area, very near to the Broca's area. We did function the MRI, and this was what was showing. The Broca's area is here, and the motor tongue area was here. And at this image, if the patient is a little bit afraid from doing awake surgery, someone may think that it's okay to do it only using neuronavigation and the populated images of the bold MRI, since we are actually around 1.5 centimeters away from the lesion here, and a whole gyrus is between me and the motor tongue area. So someone may think that it's okay just to perform the surgery using the navigation without intraoperative neuromonitoring. But actually, during the surgery, I do like to use, of course, suction probe that is stimulating the cortex throughout my surgery. And during the surgery, actually, I found that there was speech arrest. There was clear speech arrest when I was at the anterior part of the tumor, away from the Broca's area. That has been seen in the bold MRI, showing that there are still, this area wasn't active in the bold MRI, and still it caused speech arrest. Another problem is in the pediatric patients. One of the challenges in pediatric population that most of them are pilocytic astrocytomas, and favorable outcome, of course, with the higher extent of resection. And we have a problem in the DTI that there's variable myelination. The younger the patient, the poorer will be the myelination. And it's very difficult to do a bold MRI in pediatrics. One of the things also, IOM, sometimes due to different myelination and different tissue conductivity, sometimes we don't have enough data to make sure that in very young kids that, in addition, of course, to anesthesia problems, that it's very reliable. Awake surgery, of course, is not feasible, and the brain shift is challenging, of course, for any navigation system with preoperative images. This is an example. Actually, I got it from the literature, and I have another example from my institute, that the DTI was done around a thalamic tumor. It was in a pediatric patient. And this showed that the best way to get through this tumor actually is through the ventricles to the thalamic tumor to achieve as much as possible of resection, and looks like quite good resection here. It is important, of course, it is good if you have a DTI to plan for the approach. But while you're doing the surgery, and this is another example to show this is a 4-year-old male presenting with subtle right weakness. Stereotactic biopsy was consistent with polycytic astrocytoma. So we plan to do surgery for this thalamic tumor using DTI and intraoperative neuromonitoring. And it was very good for the approach. We decided to go through the temporal horn above the choroid plexus to reach the thalamus, and we did the excision in a piecemeal fashion. And here it was showing the corticospinal tract. And if you notice here, you'll find that the tracks for the arcuate fasciculus were really sparse, really inaccurate. And I think it was because of the myelination. Maybe it's because of the myelination in this 4-year-old kid. But one of the things that while we're using the stimulation, subcortical stimulation with the suction probe, 4 milliampere, we found that maybe because of the shift, we already evacuated the cyst, that actually the area that stimulated the corticospinal tract was this area and not this area. Okay, which means that, okay, it was good for the approach, but I cannot rely on it alone while I'm doing the resection. What about the speech preservation with this arcuate fasciculus? We did what we call the cortical evoked potential. We put 4 pulse strip over the Broca's area and 4 pulse strip over the vernix area, and we started to check the evoked potentials to make sure that we are keeping the arcuate fasciculus or the white matter, at least between the 2 areas, intact. And this is the post-operative MRI showing very, very tiny residual that is stuck to the cerebral peduncle. I think it is satisfactory for a thalamic tumor. What about this case? This case, for example, we needed intraoperative monitoring, and we did neuronavigation, but it was only ordinary neuronavigation. Unfortunately, we didn't have an intraoperative MRI, and I think this signifies actually the importance of having intraoperative MRI to have a better extent of resection. Even if you have a 3 Tesla MRI, still the motor evoked potential is very important in detecting the weakness. This is one of the articles that was recently presented in the World Neurosurgery, and it was showing that they had 3 morbidities with deteriorated motor deficit after surgery. Although it was important to have the 3 Tesla intraoperative magnetic resonance, but again, the gold standard is the motor evoked potential. It's not the DTI populated on the MRI. As a conclusion, BOLD and DTI MRI can help in choosing the surgical approach, but without INM due to brain shift errors of registration, image acquisition, they're unreliable in maintenance of patient safety during the surgery. Still, IMRI, intraoperative ultrasound, neuronavigation are mainstay to determine the extent of resection. And thank you.
Thank you for this great presentation. We're going to keep the questions to the end if we have time. I would like to invite Professor Russell Lonser, who is chair of the Department of Neurosurgery at Ohio State University and also president of the Academy of American Neurosurgeons, to take the podium. Thank you, Russ. You're still muted, Russ.
Sorry about that. Thanks, Isabel. I really appreciate it. I'm going to talk a little bit about patient selection for low and high grade glioma. And part of the patient selection is really based on, you heard a little about it from Mahmoud, is, how we manage the intraop resection. And no surprise to anyone here, at the end of the day, the ultimate goal is maximal safe resection with preservation of function. And there's a whole host of ways, and you heard about some of them already, to do that. It includes navigation, intraoperative stimulation, as well as imaging like DTI. The upside to doing large and extensive resection is it's associated with survival, whether it's low grade or high grade. The effect size that you have from the resection does vary by the genetics and the grade, and often or almost never, particularly with the de novo, do we know what that is. And we also know that residual disease that's left can impact the adjuvant effects of radiation or chemotherapy, as well as future trial eligibility. But we're always balancing that with the potential for deficits and loss of quality of life. When I was in training, most of our focus was on motor and language skills, but more and more we're trying to preserve cognition and executive function, and also understanding that deficits can not only change quality of life, but reduce the overall survival. So extended resection, principally for a number of years, was simply based on removing, this is a high-grade glioma we operated on last week, removing the contrast-enhancing region. More and more today, we know that doing a supramarginal resection, where we're taking a percentage or not, or all of the FLAIR imaging out, is helpful for survival. And that, again, depends on a couple of factors I'll go into in just a second. And so as we move more and more to these larger resections based on imaging, there is the possibility for the increased possibility for functional decline afterwards. And so, as I mentioned before, the goals are to remove that. And in a number of groups over the past several years have begun to look at how do we what is a moving that flare part of that flare imaging and the supramarginal resection or all of it, how does that correlate with prognosis and the different types of tumor by grade and by molecular characteristics. Now, on imaging, a lot of times we can get a sense if it's a low grade or a high grade tumor. We won't know the molecular pieces of that or what they'll be. So we're really trying to decide, a lot based on imaging, preoperative imaging. Should we do a supramarginal or just a contrast enhancing resection? So what the data shows across these lower grades that have IDH mutant or have 1p19q co-deleted, supramarginal resection does provide extended survival. Same with an IDH mutant high grade. And again, we can't tell this looking. So at some point, it's a little bit of a false argument. And so our goal typically is to do a supramarginal resection based on flare. The one area where it's not clear is the wild type, IDH wild type glioblastomas, where a number of groups have seen no advantage with the supramarginal resection, where some have seen with at least 20% resection of that flare and up to 60%, the Mayo Clinic showed this, that you can have increased survival, but it's still out there. So nevertheless, we will approach and try that supramarginal resection. There's tumor factors, functional anatomy, patient factors that really go into the preoperative selection and management of these patients. The tumor factors we've discussed a fair amount about, and that's really what they look like. Do they look high grade or low grade? Is there significant mass effect, midline shift? What do we suspect their molecular types to be? And again, based on a lot of stuff we have known for a number of years based on MR imaging. And then it's really the functional anatomy. You heard Mahmoud talk about this a bit. Where is the eloquent cortex located? What does DTI show around tracks? And the use of intraoperative mapping, as he described, as well as ultrasound in intraop MR can be useful as well in some cases. And but it really comes down when it comes to when we look at those factors, it's also the patient's absolutely critical. Age, frailty, comorbidities, many of them are on anticoagulation. And then when we start to look at can they tolerate an awake operation based on mass effect, age, cognitive and executive functions can all impact whether they can do that. And also, do they have an excellent support system or a support system that can help with rehab if they need it, even for a transient period of time? And really, what's the patient's desires at the end of the day? So when we just talk about low grades, when I first started when I was first started training, we typically would watch these and watch them grow. We now know based on UCSF data that these tumors will grow principally in a linear fashion over time. And these can often grow into eloquent areas where they weren't previously there. Many of these patients, particularly young ones, have seizures associated with it. And so the idea now is for early maximal safe resection of that flare region, again, at minimum getting biopsy, but then providing maximum quality of life and into our tumor-free progression or survival. Primary goals, no surprise here again, maximal extent of resection, durable seizure control. Again, the UCSF group estimated seizure control at a minimum of 70% resection. Ideally, though, the goal again is to remove that flare region. And again, to preserve function, including executive function when at all possible. And again, you heard earlier, we use mapping to do these things, subcortical, cortical mapping. Intractography is helpful, and Mahmoud showed several nice examples of that. High-grade glioma, again, looking at the same type of, when we're viewing these patients, can we resect this? And this is really, as you know, for cytoreduction and getting these patients into adjuvant radiation and chemotherapy. When Michel Lacroix and Ray Savoya wrote that paper 25 years ago in 2001. They really were proponents of greater than 98% resection. Nader Sinai, Mitch Berger published a decade later published a paper that showed you could have improvements in survival with at least 78% resection. So that goes into the whole patient selection. Do you need to biopsy, or can you at least provide a significant resection to provide them meaningful survival in a safe way? High-grade glioma, it just kind of recites that, what are the indications for that in the patient selection to prevent or improve them from neurologic decline, avoid steroid dependence, eliminate mass effect, obviously getting the tissue diagnosis, molecular profiling, and again, accepting, is this, worth risk to the patient, understanding the areas with preoperative imaging. Again, it's the same maximal safe resection and avoiding new deficits at the end of the day. And this is important, as I mentioned earlier, because we don't want to, deficits do shorten life expectancy in high grades, and they reduce the runway for adjuvant therapies. So when we look just both at the high grade and the low grade, and we look at patient selection and the goal of maximal resection, low grade gliomas we typically operate on as early as they're detected, provide maximal safe resection. That provides functional preservation, potentially reduces the risk for degeneration into a higher grade tumor, which obviously shortens life expectancy. High-grade glioblastomas allows us to improve overall survival. It's a one factor outside of the genetics and the imaging appearance that allows us to do that. And the extended recession is, as I mentioned before, the modifiable risk. And again, cytoreduction, the goal there by removing the flare-related areas as well, if possible, the supramaximal. You've heard about some of these. We can use functional mapping that are intraoperative stimulation, cortical, subcortical, motor evoked potentials, SSEPs, the imaging piece you heard about. Some people use, and many of my partners use 5-ALA fluorescence. I don't personally use it, but a number of my partners do to help with the benefit from resection and as well as intraop MR. More recently, we're seeing more minimally invasive ways. Steve Kalkanis and their group at Henry Ford nicely showed that you could treat even in stages with just laser interstitial therapy in percutaneous incisions, these large and sometimes expensive diffuse insular gliomas with a great deal of success and minimal morbidity. So the last thing I'll talk about is, because we're balancing patient selection with outcomes, quality of life domains become absolutely critical. And there's various outcomes you can use. I'll just refer, this just came out 2 months ago in Lancet Oncology. It was the Rano group. Began to look, specifically at what's the best ways to measure outcomes preoperatively and postoperatively as well. So I think, as you see, patient selection as well as tumor management is absolutely critical. Low grade and high grades, maximal cytoreduction, but they achieve ultimately different goals at the end of the day, but both are critical. And adjuncts can expand resection, as you heard about, and more of these are developing, and many of these are becoming lower and lower cost. And it's absolutely critical to measure qualities of life and align them with the individual patient wishes. So thank you very much.
Thank you. This was really awesome. We're going to take some questions at the end, and we're going to continue on with Professor Drogba Landry from the Côte d'Ivoire. Thank you for joining us tonight.
It okay? Do you see me? Do you hear me?
We can see and hear. Thank you.
Okay. Thank you very much. Thank you, Professor Germano, to invite me to participate to this panel. Professor El-Wabi is not here. I'm the only Francophone in the of the panel, so excuse my English. Talking about development and implantation of awake surgery is talking about 23 neurosurgery for 22 million population. It's about one neurosurgeon for 985,000 people, far from one neurosurgeon for 200 people, 1,000 people recommended by the WHO. So we need now to be right to the rule, we need 130 neurosurgeons. But we try to go ahead, and we are 23 in 5 neurosurgery department, 2 in Abidjan, the big city of the country, 2 in Boaké, in the center. In the capital, we have 1 department, and new department in Adzopé, close to Abidjan, with 1 neurosurgeon and 2 neurosurgeons in San Pedro, the second port in of the country. The next step to create a department in the east and the west and the north, and we have to think about this area of my country is the area in the forest of cocoa, is a high density of people. You have to think about create a department of neurosurgery. I'm from teaching hospital of Yopougon, Abidjan. It's my hospital, and last year we have 746 surgeries. 85% were adult. More than 50% was cranial, and brain tumor presented 22.5% of surgery, of which we have glioma. Glioma is a common tumor in our practice, and we know that the surgery is often the first treatment, and it's a real challenge to worldwide, and I think more in LMIC because, as Professor Colby said, we need tools, we need machine, we need device, we need the new technology like a microscope, neuronavigation, intraoperative neuromonitoring, fluorescence. And we need also visions, will, human resources, and MDT to help to deal with this disease. And it's optimized by awake anatomy to perform awake mapping to be sure to be safe in the surgery. I looked in the internet and I saw that a program in sub-Saharan Africa started in Tanzania, South Africa, and Morocco in 2010. About development of an implantation of awake surgery in my country I invite you to read this paper written by my colleague. It's about the history of neurosurgery in Côte d'Ivoire. She noted that we have 4 periods. The first one was the training of the first neurosurgeon, Dr. Kanga, Professor Bazizé, the father of the neurosurgery in Côte d'Ivoire, Professor de Chambenois, Professor Varley, and the second period was the real period of the beginning of neurosurgical activity. They operate all they could. They started with vascular. My master performed surgical clipping of aneurysm, and skull base and spine. They started with that, but he said to me, we didn't have a good outcome for glioma surgeries because we didn't have support. The oncology department was not developed, and we don't have many treatment. So the third period is the period when the surgeon hesitated to operate gliomas. So that's why in this paper, Indri and collaboration showed that meningioma represented the most frequent intracranial tumor in Ivory Coast in this period, but it was a bias because we didn't operate anymore because of the bad outcome. And it's a period we create the local neurosurgery training program. After that, the first step was 2012, and we create more subspecialty according to a vision of the master. And in this period, we improve the training of neurosurgeon, and according to a vision, also neuroanesthesiologist. And we have a key moment in 2017. We have the first high-field MRI and new equipment with neuronavigation, EONM microscope in a private hospital. In 2018, we have the creation of the first center of oncology with radiotherapy. And in 2000, the year after, we create the neuro-oncology MDT with subspecialty. And now everything become possible. But we have some problem to solve. First one is we don't have many physicians to cover all the place. So we don't have neuroanesthesiologists in the same place with the neurosurgeon, like I show. In CHU d'Angers, we have neuroradiologist. In CHU de Cocody, we have neuro-onc and neuropathologist, the only one. In CHU de Tréjus, we have ped-onc and general-onc. In pediatric hospital, we have ped-onc. In oncology center, we have radio-onc and general-onc. And in CHU de Yopougon, my hospital, we have neurosurgeon. So you have to understand the Ivorian context to work. And the situation is that we can do awake surgery only in private hospital. So you think about organization to have all the professionals in the same place. It's in that context, we have the first case in 2019. It was a patient with 34-year-old. We have focal seizure and motor deficit in the right hemibody. And as you can see in T1 Ghetto in Hollandic area. And we discuss is in we perform a DTI, as my colleague said. We perform a DTI to help us to find a good approach to be safe in the resection. And the first MDT say we are in the Hollandic area. We start with a biopsy, neuronavigation biopsy, and the result was a gematocytic astrocytoma grade 2, a low-grade glioma. So we decide to remove the tumor, and I say I can try in awake craniotomy. And at this time, we were two in the Ivory Coast to know this topic, me and the anesthesiologist. And so you have a meeting to think about how we can do without neuropsychology and neurophysiologists. We have two. And I decided to call my colleague in Lyon, France, to help me to monitor, because the neurologist didn't want to work with us. I don't know why. And the first cases, the first cases, the first cases was, I want to, what can I do? This, yes. No, it doesn't work. Sorry. So the first case was this case, and the anesthesiologist was speaking with the patients, and I was monitoring. How can I okay. And after we can see post-operative MRI. We have a good resection, and the pathology confirmed with immunochemistry the gematocytic astrocytoma grade 2. I think it will work. No. Yes. And I can see the patient working 3-month follow-up, and the resection was we were satisfied the resection 3-month of follow-up. The second case, we published this first case in local journal of African journals on neurological science in it's an African journal. The second case is not about glioma, but in a meningioma neurologic area, and we do it to improve our experience in this practice, and was a pastor with focal seizure and hemiparesis, and imaging showed a big meningioma in Rolandic area, and we decided to do it in awake surgery, craniotomy. The positioning, we choose it for a comfortable place to a patient. We use the monitoring also. We were comfortable. We were confident, more confident in the second case, and after opening we go to the test, and the anesthesiologist is also the neuropsychologist. He tried. He asked patient to move, because yes, he moved. He asked the patient to move, and regularly, to be sure we are right in the removal, and we continue to remove the tumor. It was a big tumor. It was hemorrhage with many hemorrhage, and during the removal, we have many. Yes, we have yes, we have hemostasis, and we have seizure during the surgery. So we use code freeze to stop the rising, to stop the seizures. Like this, you put many. We don't have many options. It was a focal seizure, and the anesthesiologist talked to the patient to stay quiet and stop the seizure. And after that, the removal, we go to the third the asleep phase, and to the closure. And after, we have a good imaging after the resections, and on the T1 Gedo, and also to flare sequences, we have a good imaging. In the day 2, we saw the patients, and we have no complication, no motor complications, and at day 5, it can move all the. So the big message for us is now it's possible we can, because it was a dream before, and now it's possible. I think vision is the key, because we have to be patient. You have to develop. You have to with your colleague. You have to. It's very important to be patient, to do those things the best day, the best time, at the right time. I think nothing can stop if you want. If a problem remains unsolved, maybe it is not maybe it is not well defined. Future for us is to organize, to improve our organization, because it's very difficult, and we decide to improve our human resource. So we target some neuropsychologists, neurophysiologists, neuroanesthesiologists to learn, to help us to work together. And the goal, the main goal, is to develop it in public hospital. And I'm very interested by NewsNav, because he's good for us, for public hospital. I will ask, is my question, how can you call to talk to you to have it in my hospital? And we have to improve our experience. We finish with that. We have a small cohort study about intracranial high-grade glioma. We manage since we start the neuro-oncology NDT, we have about 19 patients, and all have STOOP protocol, and we have 33% median survival of 11 months. It's a small series, but we improve day after day. Thank you very much for your attention.
Thank you for this spectacular lecture. We are just at the hour, but I have 4 very quick questions. So if the panelists agree to stay another 2 or 3 minutes, we can probably ask the questions. I'm going to start with you, Professor Dagba Landry.
Slowly, please. Slowly. I'm francophone.
Je m'excuse. So the question is, for the young neurosurgeons that are listening to us, and possibly the medical students, could you tell us in a few words, why should they pursue a career as neurosurgeons and taking care of patients with brain tumors? What makes it important?
Repeat, please. What?
Pour les jeunes neurochirurgiens qui sont avec nous ce soir, si c'était possible, si vous pouvez dire pourquoi c'est important pour vous d'être un neurochirurgien et surtout de s'occuper de ceux qui ont la tumeur cérébrale.
Alors,
you can say your comment in French. I think it's okay.
In French, it's okay.
Of course.
Mon histoire est un peu particulière, parce que, en fait, je voulais être neurologue, parce que ma mère avait eu un problème de neurologie. Et puis finalement, je suis tombé en neurochirurgie par hasard. Quand j'ai vu un cerveau ouvert lors d'une première garde, j'ai dit, je quitte plus la neurochirurgie, c'est ça que je veux faire. Mais je pense que ce que je ressens, c'est que quand vous opérez un patient qui a un problème de neurochirurgie, il vous confie son cerveau, il vous confie la chose la plus importante qu'il y a dans son corps, parce que the brain is the most important thing you have. So, vous avez une grande responsabilité, et prendre soin de quelqu'un d'autre, je pense qu'il n'y a rien de plus beau, de prendre de son temps pour aider les autres, pour donner la santé. Je pense qu'il n'y a pas mieux. Et donc, pour moi, la neurochirurgie is the best.
Thank you so much. And we're not going to translate it because a Google Translator can do that. Professor Lancer, I have a question for you from the audience, and that is the Lancet Oncology that you showed, and you mentioned that there are options, or at least there are some guidelines on which are the methodologies to follow to really look at outcomes. Where are we going with quality of life for patients with brain tumors? Where do you see the next steps being?
Yeah, that's a great question. And I think, as I said before, when I was in training, we were concerned about language and motor. I think we're now more concerned about executive, cognitive functions, particularly with these tumors. And I think that's the next place. And you'll see that in that article, where they do give defined, cognitive testing and things like that to really assist with that. But I think that's the next area that will be that will impact patient selection potentially.
Because one of the questions could be that the supramaximal resection might have an impact on cognitive functions that perhaps up until now, we as neurosurgeons have not really focused, right? Just like you're saying, patient can talk, the patient can walk, the patient can. And so do you think that that will be taken into consideration as we move along?
Yeah, I think it will, but I think the other part of that is it will be really patient specific in the sense of some patients may be willing to accept some decline there with the possibility of extended survival, particularly with the high grades and things like that. So yeah, but that's a great question.
You and Professor Mahmoud Abbasi, the question about images is so interesting that with images now we can do things that before we were not able to. And so the question for you is, do you think that AI, artificial intelligence, will even enhance what we can do and see with DTI?
I think so. It may help in choosing the approach. I think this is mainly what AI would help, and maybe it will expect complications post-operatively from how the arrangement of DTI. In addition to this, as Professor Lancer has said, that later on, we are speaking about cognitive functions, maybe doing DTI to other stuff, for example, in cases in PEDS, when we are trying to do now the dentatorubral-thalamic pathway to determine the mutism, for example, the risks for mutism. So I think prediction of complications will be also an important role for AI.
Thank you. And the last question to Professor Golby, you got a lot of people complimenting you about this brilliant system, very easy to use and also not necessarily expensive. And so the question is, could it be even less expensive and perhaps use the camera that is on the cell phone rather than the $250 or $300 cameras? Do you see your technology evolving and becoming even less costly?
So that's an interesting question about the trade-off between cost and performance. And we decided that we wanted to achieve nearly as close as possible to the performance of these large commercial vendors, because that's what every patient deserves. Is it possible that a phone might be able to achieve that kind of accuracy at some point? Yes, it may very well be, but it does really, I think, limit what you can do. So, for example, in order to do 3D visualization, you need some separation, and the camera in the phone is just one camera, and it does have some ways of measuring distance, but it's not nearly as precise as triangulation. So we thought that this was a pretty good trade-off. It's less than $5,000 for the whole system. We also envision this being, it's less than $5,000 cost. It depends how we end up distributing this system. Our goal is to do this as a nonprofit. But our goal is, I mentioned it was portable, not as portable as an iPhone, but it's pretty portable. It's a small suitcase, not even a suitcase, it's a briefcase. And so the surgeons who operate at multiple hospitals, as you alluded to, Professor Drogba, many surgeons in the developing world have to cover both public and private hospitals, that they would own the system, and they would control it if it's within their, possibly within their budget to do so. And compared to renting these systems, so there's a number of countries in which these systems are made available on a single-use basis. So last month I was in Mexico when this large cancer hospital needs navigation, they have to rent it. And it's about $700 US each time. Plus they have to use the consumables. So putting it in that context, I think I'm very biased, but I think we chose a place where we have a reasonable trade-off between performance and cost.
Excellent. Thank you so much. Sorry for being a little over the hour, but I think that this panel was fantastic. And before we close, I really want to thank Professor Abdesamad Elouabi. Unfortunately, probably was taken by surgery tonight, couldn't join us, but he was instrumental in putting this webinar together. And with that said, thank you, everybody, and see you hopefully at the AANS.
Thank you so much.
Thank you so much.